Thank you, Dr. Hudson. Thanks to both the chairs, co-chairs, for this very, very kind invitation. Shout out to Eric. We have, from RPI, we started a new partnership and a collaboration with IQ, which is right next door. I have students there, and this is an awesome institute, as well as UCLA. So I'm an engineer, and for engineers using computers to do modeling, for simulation, for computer-aided design, as well as virtual environments for training pilots, nuclear engineers, and I have both nuclear engineering and aerospace engineering as part of my department. That's decades old. But I'll be preaching to the choir when I say, of course, this too, that I have no disclosures, but that surgery is one of the most complex tasks that human beings are asked to perform. So it involves the performance of very complex tasks, which involve motor skills, complex tissue interactions, hand-eye coordinations, two-dimensional field of view navigation, reduced haptic interactions, and so on. But not only that, surgeons also have to work in a very complex environment that is replete with time pressures, competing cognitive inputs, plurality of goals, team communications, and fatigue for long-duration operations. So whenever you have a complex task being performed in a very complex environment, you can be absolutely certain about one thing, and that's error. So there are many frameworks of looking at human errors that have evolved over the last century or so, but one of those that I find very illustrative and translates quite well to this field of surgery is this SRK framework of Rasmussen's, which stands for the Skill Rule Knowledge-Based Framework. It's pretty simple to understand that, for example, tasks like suturing, an experienced surgeon can suture with the eyes closed, it's automatic, but still, even with a high familiarity with the task, there can be chances of errors because less attention is being paid. For example, I start driving out from my office intending to go to a friend's house, but I'm driving along and then I find myself in my own driveway. Happened to me, I don't know whether it happened to you. So there are certain surgical tasks which are rule-based. So you're basically following rules, and then the errors could be due to wrong rule, misapplication of the correct rule, or non-compliance with the rule. Now, what happens if you are in an environment, for example, the gallbladder anatomy is sort of blurred, it's very difficult because of the disease states, and it's very difficult to make a decision as to whether or not to cut the cystic duct, because you might be just cutting the common bile duct. So that requires effortful thinking. So then you have to then you are in this realm with low familiarity, which requires high attention. And basically, what I'm going to tell you is that, well, physical simulators are good at this part, are good at this part, but it's extremely difficult to create physical simulators that emulate the very rare but extremely difficult situations that occur in the operating room. Those are the most difficult to train for, and I'm going to make a case that that's where I see tremendous application of virtual reality. And add to that the effect of stress. So there is this inverted U relationship between performance and stress. So with increasing stress, performance usually goes up, there's a sweet spot, and then more stress does not help. It can be more catastrophic than this shallow decline. So basically, as I said, there are physical simulators all around us, and I think we'll have need for them into the future. But to be able to deal with the complexities that are associated with, for example, the knowledge-based tasks, and to understand how stress affects performance, it is critical for us to think beyond physical simulators. And I think that's where virtual reality has a lot to offer. And in terms of virtual reality, what I'm talking about is a purely immersive environment where the human user interacts with virtual patient models using his or her vision as well as other senses like haptics, or audition, and so on and so forth. And this presents a tectonic shift in the way that surgeons can attain proficiency, that is training, can come up with new devices and protocols, or plan new procedures, either preoperatively or intraoperatively, depending upon how much of a real-time situation that is, and that deals with the data explosion that Dr. Hudson was talking about. But I think this is critical to understand. This is because we can actually develop a very high fidelity environment where people can can work on risk-free on simulations in a risk-free environment, and just by literally the click of a button, we can ramp up the incidence of rare conditions, which is absolutely not possible in the real world. And objective evaluation can be done at a level of granularity, again, that is not available in real life. So to me, virtual surgery or virtual reality is really a super reality environment where we can use our imaginations, use our clinical judgment, essentially, to create these virtual worlds with an indefinite degree of complexity, which is absolutely not possible in the real world. So we have put down some of our thoughts in this paper that appeared a couple of years ago. So rather than talking about all the kinds of things that are going on, I'll just focus on a few quick points and talk about where we're going with all of this. So we partner significantly with Beth Israel Deaconess Medical Center in Boston, and we have other collaborators like University of Buffalo. And we've been working on a variety of simulation technology over the past couple of decades. So of course, examples of psychomotor simulators are, for example, the virtual versions of the FLS tasks. By now, you're familiar with the FLS. We have running this program for more than 10 years. Now, the advantage, of course, is using these kinds of simulators is to get a high degree of fidelity and to be able to generate the scores automatically without the presence of a proctor. But the point is, how reliable are the scores? So now, in the next iteration of this technology, we have been looking at directly the brain. Because you can look at different kinds of measures, like you can look at the kinematics of hand motion, you can look at pupil movement, and so on and so forth. But at the end of the day, what is receiving the information and making decisions is the human brain. And using near-infrared spectroscopy, we can actually in real time capture what the brain is thinking and how it's trying to learn, right? So what we found is that integrating with that new AI algorithms, we could reduce the misclassification error to less than 5%, where that is about 60% for the current FLS metrics. And as you can see, we have to use actually 3 areas of the brain: the prefrontal cortex, the supplementary motor area, and the M1, which is the motor cortex, to be able to reach that level of fidelity of the scores. And this has been published in Science Advances last year and reported in the Wall Street Journal in October, first week of October. Now, what about stress under training, right? So surgeons are exposed to a tremendously stressful situation, but how do you capture that in kind of a skills lab? So this project shows the Gen 1, or the first generation simulators that are in vogue right now. If you go downstairs and look at the learning centers, or if you look at the demo, the companies that are selling these, they're selling those kinds of things, where it's just the user interacting with the virtual reality environment, but either be in a head-mounted display or directly a computer monitor. But now, to be able to introduce stress, we have the second generation of Gen 2 simulator, where we have 2 recursions of virtual reality, where we immerse the surgeon in a virtual OR where the patient is also virtual, right? So now the reason we do that is because now we can introduce the different stressors individually or together and find out the effects in a controlled environment. And what we see is quite interesting and illustrative. For example, we ran a study with 11 medical school students in Texas. And basically, there was a pretest. There was a group that did not undergo training, a group that underwent VR training, and the other one with VR and cognitive load. All the groups the groups with VR and VR plus cognitive load are allowed to actually become masters in the particular task that was being performed. And we can see that in the retention test. There is no statistical significance between these groups, and they are different from the control group. But now, if all the 3 groups are now asked to perform the same task in a transfer task, like after a couple of weeks, in an environment that includes cognitive load, then what clearly turns out is that the group that is trained with cognitive load performs better than the other 2 groups. A purely cognitive task, which is now a part of what is called the Fuse, again, initiated by Dan Jones, and then we developed the hands-on component of Fuse called the virtual electrosurgical skill training. So it's a cognitive task, and it's very difficult to develop a mental model of what really Maxwell's equations mean. I mean, that's really what's happening. You're using energy-based devices on tissues, and we have to understand how they're used, what the power settings means, and so on and so forth. What consequences do they lead to? So for that, we had another project where we took, from Fuse, we took 21 learning objectives and created 3 major procedural simulators. One is to understand monopolar and bipolar devices. The other one is to understand operating room fire. We read about the fire triangle in elementary school, but it's very difficult to actually cope with an operating room fire because of the stress that creates on the clinician, right? And we have shown that using transfer of learning studies that is indeed the case, and that's actually published in Surgical Endoscopy. So the next version of this is the virtual intelligent preceptor. That's how we actually now building an intelligent agent to help the learner by actually having a model of the trainer, a model of the trainee. And this VIP simulator is right now being tested. So if you have not actually seen that, it's awesome, it's cool, check it out in the Learning Center. So what I see as the future is really that virtual reality is one vertex of this triangle that is going to evolve in time together with artificial intelligence, the algorithms that are coming out in artificial intelligence, and non-invasive neuroimaging. So with that, I'm going to conclude my talk, but not before I thank all my collaborators who really do all the work, and I'm happy to champion them along. Thank you so much.